Good morning, everybody. Thank you for coming today. We have a great crowd, and it's going to be a fantastic day. This is the first, hopefully, annual Community Smoking Cessation Symposium, and I want to emphasize community. We have a lot of diverse people here today that's going to bring what we learned back to the community and help for our goal and everybody's goal of getting people to stop smoking. I'm Theodore C. Friedman. I'm the chairman of the Department of Medicine at Charles University and chairman of the Department of Health Technology Work Group, and I'm along with Dr. Hurley, the PI of this grant. Dr. Hurley is my good colleague here. He's the director of addiction medicine at Los Angeles County Department of Health Service. And the person who really made this symposium happen is Norma Matsume. She did a fantastic job of organizing and putting everything together today. We'll give her, I think, applause now. Yes. Okay. She's a community engagement specialist and really is superb at what she does about bringing the science that we do to the people in this audience and others around the city of Los Angeles. There is no commercial support for today's activity. If you guys want to donate some money, it's okay. No, we're okay for financials from our grant. None of the speakers or planners today have disclosed any financial interest related to the content of the meeting. So our goals for today would include, at the end of the day, we want people to understand why smoking cessation is important, discuss available FDA-approved medications for smoking cessation, list smoking cessation resources in Los Angeles County Health Agency, describe why certain populations are at a higher risk for smoking and or the effects of smoking. And really the main thing is we want to inspire and educate you to get your participation, your patients and your clients to stop smoking. There is continuing educational credits and hours. A total of 6 units are available. Most of the credits are provided by the UCLA ISAP, Integrated Substance Abuse Program. They're providing the credits. You can read this here if you're interested. But basically, it's 6 hours of credits for LMFTs, social workers, LPCCs, LEPs, and people will get their certificate. I'll talk about the slide in a second when they leave at the end of the day today. Please put your cell phones and pagers on vibrate. Please complete the evaluation form at the end of the day. And we're asking everybody to complete the evaluation form, whether you're getting your CEs or not. They'll be provided at the end of the sessions for those who stay the entire session. We can see individually if you have to leave early what we'll do for you, but hopefully people will want to stay. Emergency exits are basically in the back. Bathrooms are around the corner to the left here, plus there's some in the front there. Melissa, do you want to come up for a second and talk about the evaluations? Are you here, Melissa? Okay. So she'll be in charge of the evaluations. So it'll be pretty standard. I think when you leave today, you'll get your certificate, and the evaluations are in the packet. The talks will be posted on. There's a Dropbox that I think Norma sent out the link for. They'll be on that, and they'll also be on this Charles University Research Center Diversity. It's called. This will be also available in about a week. The agenda today, it's going to be a great agenda. Dr. Hurley, Norma, and myself are giving the introduction here. Dr. Laura Ray is going to be talking about characteristics of people who smoke and smokers who use other substances. Dr. Hurley is going to be talking about smoking cessation treatments and readiness to quit. We have a break, a 15-minute break. There'll be some food out in the lobby over there. You can use the bathrooms again over there or in the front. We'll have a panel of Los Angeles community provider experts. We'll have talk about challenges, obstacles, and keys to smoking cessation from a panel of current and former smokers. We have lunch from 12 to 1. Again, it'll be in there. Most of the space in the courtyard. Fortunately, today's a nice sunny day. I don't think it's going to be too hot, so it'll be really nice to go in the courtyard and talk to some other people. Please use this as a networking opportunity. Feel free to talk to other people in fields that you want to connect with. In the afternoon, Latasha Dixon is going to be talking about group therapy for smoking cessation. Brianna and Julian, my two great students, are going to be talking about e-cigarettes, friend or foe. We have another break from 3 to 3:15. At the end of the day, we're going to have a panel talk about Los Angeles County Tobacco Control and Prevention Program activities and community resources for smoking cessation. We'll wrap it up about 3:45 and get you guys home hopefully by 4 or so. Tobacco use disorder is the leading cause of preventable deaths worldwide and is undertreated in the public sector, such as where many of you guys work. cigarette smoking constitutes a major risk factor for cardiovascular disease, such as heart attacks and strokes, chronic obstructive pulmonary disease, lung cancer, type 2 diabetes, and fatty liver disease, which my student's going to talk about a little bit in the e-cigarette presentation. The prevalence of smoking was 31% among patients below the federal poverty line. So this is much more common among poorer patients. So therefore, smoking is considered a health disparity. In Los Angeles County, 1 million adults in Los Angeles County smoke. That's more than populations of, I think, about 30 states in the country or so. So there's a lot of people in Los Angeles County that are still smoking, in spite of the evidence that smoking is very detrimental for your health. 1 out of 7 deaths is caused by cigarette smoking. Smoking costs $4.3 billion per year, $2.3 billion in direct medical costs, $2 billion in indirect costs such as low productivity, sick, being away from work for being sick, etc. More than 500,000 non-smoking adults and children are exposed to secondhand smoke. The top 5 causes of death are associated with tobacco use, including cancer, heart disease, and lung disease. The good news is smoking prevalence is going down across the country and in Los Angeles County. This was 18.1% in 1999, down to 13.3% in 2015. So this is a good sign. It's trending downward, and I think it's going to continue to trend downward, hopefully with you guys' help, to get your clients and patients to stop smoking. So the goal is to have 12% of people, and this is across the different SPAs in Los Angeles County. SPA stands for Service Placement Areas, and it's the different parts of Los Angeles County. SPA 6 is where Charles Drew University and Martin Luther King Hospital, where I work, is, and it has one of the higher rates of smoking. The downtown here, the metro area, is also have a pretty high rate here. The west side, though, has one of the lowest rates. So I think we want to try to help with the disparity of this and have the places that are the highest smoking, the Antelope Valley, the metro area, the SPA 6 area, the SPA 6 South area, go down in the rates of smoking, so everybody is at this 12% or less. Obviously, the less people smoke, but I think we especially have to target the inner city population, the lower income patients, because they're at a higher rate of smoking in Los Angeles County. In general, the much more males than females smoke, and in general, it's highest among Latinos and blacks, lower whites, and at least for the females, lower for Asians. For the males, it's actually a little bit higher for Asians, but you can see in general the Latinos and the blacks have a little bit higher rate, but some variability. It's interesting, Latino women are pretty low. It's also associated with educational level. The people that have less than a high school education, 17.7% of them smoke. The people with a college degree or more, only 9.3% smoke. So it goes down as people get more educated, but we want to target all the population, especially the people that have lower education, to get them to stop smoking also. Brian?
Good morning, everybody.
Good morning, Brian.
Can you hear me okay? Yeah. So my name is Brian. I'm an addiction psychiatrist. Thank you for being here today. Within this context, I wanted to talk for a moment about the Los Angeles Health Agency, which is comprised of the Department of Health Services, Mental Health, and Public Health. And these are the county-operated departments that provide the safety net to the safety net, right? So the Department of Public Health has tobacco control. The Department of Mental Health directly operates in mental health centers and contracts out, especially mental health money. And Department of Health Services owns and operates the county hospitals, as well as a set of community clinics. The Department of Public Health, again, has tobacco control and prevention program that aims to lower tobacco-related death, disease, and disability in LA County. And I would point out that this project, the TRDRP-funded project that I'm going to go over briefly, is actually a true agency project. It involves Department of Public Health tobacco control and prevention. It involves the Department of Mental Health, and it involves the Department of Health Services. Okay, so within the LA County Department of Health Services and DMH, both have county-operated services. And both actually, the Department of Health Services is very interested in integrating behavioral health into primary care, which the county clinics historically have not always had integrated behavioral health. And there's been several iterations of this, but there's a renewed interest in integrating behavioral health into county-operated primary care. And the Department of Mental Health is committed to broadening a focus of health and wellness that includes smoking cessation services. So what is currently being done for people with tobacco use disorder in the Department of Health Services? Well, we know that DHS is screening more and more smokers, and we have identified 17.3% of individuals who receive their services, the Department of Health Services, and this is particularly primary care patients, are identified to be smokers, which is higher than the statewide average of 12 to 13%, depending on the year you're looking at. But of the people that DHS identified to have tobacco use disorder, only 1 in 5 were actually documented to receive an intervention, like counseling or referral to the California Smokers Helpline or medication for smoking cessation. We know that the rates of smoking are much higher in people that receive mental health services. And when we look at the data for the Department of Mental Health, almost 30% of clients of DMH were identified to be smokers, and counseling was only offered to about 18% of them, and the medications were prescribed less than 2% of the time. One of the things we know in the literature is that community mental health programs oftentimes have the lowest awareness of state quit lines. So everybody in this room now gets to be fully aware of the California Smokers Helpline, no buts, which offers telephone services in a whole number of languages, offers a whole number of online resources, nobuts.org. I know when I see clients at DMH or when I see patients at DHS, I have print out to the California Smokers Helpline on the desktop ready to print anytime I identify somebody who smokes cigarettes. But I think that we can do more than refer people to the California Smokers Helpline. In other words, I think that that's necessary, right? I think it's important that people can access free services. But that's not the same as getting integrated smoking cessation treatment, behavioral treatment delivered in clinics, and medication treatment delivered in clinics, which are on the menu in addition to telephonic counseling and web-based support. So Dr. Friedman and I worked together and put together a grant funded by the Tobacco-Related Disease Research Project called Embedding Comprehensive Smoking Cessation Programs into LA County Clinics. And the strategy is to take our existing program and then integrate smoking cessation medications plus smoking cessation counseling. That's based on an already validated model. So actually the VA has been doing these integrated smoking groups with medication management now for a long time. We have gotten the Department of Public Health IRB to approve our protocol, which is to support the delivery of medications for tobacco use disorder and counseling for tobacco use disorder into county-operated services. And this is, just to be clear about kind of what we're proposing, or what we proposed and got funded, where it's a research project. And it's not a research project to test whether medications work or to test whether counseling works. These are validated. We know that they work. It's to see what's the best way to implement these services. And so we've identified 6 county-operated community mental health centers and 6 county-operated primary care centers or patient-centered medical homes. And we're resourcing 5 in each arm, or 10 clinics, to actually deliver. And we being the grant, the grant committee, is resourcing those 5 clinics in each site, so 10 clinics altogether, to deliver these integrated services. And we're going to get a 6th site in each arm, or 2 other sites. And we'll look at smoking behavior in the treatment as usual arm so that we can compare. What's the effect of offering these services? Again, it's not a clinical trial. We're testing, do the services work or not? We know the services work. We want to see what's the real world effect of doing these services in the county-operated clinics. So it's not a clinical trial. It's what's called an implementation trial. Does it actually work in the real world? Because you can do things in a clinical trial, but does it actually work when you put it into practice? So that's the question we're looking to answer. These are the county sites: MLK, Roy Ball Community Health Center, Harbor East Medical Center in the Carson campus, Harbor East Medical Center in the Lomita campus, Humphrey Comprehensive Health Center in Mid-Valley, and then the DMH sites: Arcadia, East San Gabriel Valley, Harbor East Mental Health Center, South Bay, West Central, and West Valley. The implementation evaluation is to see to what extent are sites able to adopt these services. And we're offering training and technical assistance and decision support. And then we're evaluating what is the smoking behavior of the clients or the patients at these sites. And so we have study coordinators who will be on site and getting referrals. And if somebody is interested in actually being a study participant, there's a couple criteria. You have to be 18 years old. You have to be currently a patient or a client at LA County, DHS, or DMH. You have to be an existing patient or client. So I know this is a community symposium, and I know that many of the folks in the room are from agencies that serve people who are not necessarily county patients or county clients, and you do have to be currently enrolled as an active LA County DHS or DMH client. You have to be smoking at least 5 conventional tobacco cigarettes a day. And by conventional, I mean not vaping, right? Like tobacco cigarettes that you put on fire and inhale smoke. And the client has to want to reduce or eliminate their tobacco product use. And they can't have taken a medication for smoking cessation in the past 30 days. And for those people that are interested, again, the county patients that are interested, they can receive up to $50 per year. And we're still waiting on a few final approvals before we're able to launch. So this is, when we eventually launch recruitment, this will be the inclusion criteria, but we haven't actually launched recruitment yet. It's a 3-year, so we're assessing over the course of a year. And so there's a baseline survey, and then follow-up surveys at month 3, 6, and 12. And the whole study goes for about 3 years. Right, so we'll be recruiting over the course of somewhere around 2 years, and we hope to recruit 120 patients from the 12 sites, and then 1,200, 100 from each site, so 1,200 patients or clients is our total recruitment number, and we're not just assessing based on surveys. We're actually doing both carbon monoxide breath testing and urinary cotinine, which is a metabolite for nicotine, to see is there some validation of what people say about their smoking behavior. So we're really looking for people stop smoking, and can we verify that by carbon monoxide testing, cotinine testing? And then we're also interested in quality of life. How does this affect people's depressive anxiety symptoms? What's the stability of smoking abstinence? And we're also interested in seeing which are the components of the treatment in the real world that seem to be the most effective. Is it a particular medication or medication combination? Is it the fact that somebody participated in a group at a certain frequency? Is a combination of the behavioral therapy? Or we're interested in trying to tease out what seem to be the real world components that seem to make the biggest difference. And here's the contact information for our study coordinators for once we open recruitment. These are the folks that will be helping coordinate the recruitment. And with this, I'm going to turn it over to my dear friend and colleague, Norma Matube. No. Any questions about the project or the study that we're proposing? Which, let me be clear, is specific to the county-operated services. But the goal is that once we're done, we'll have a toolkit and a manual and a bunch of stuff that can be disseminated, right? So that everybody in LA can take advantage of what we learned in implementing these services in the county-operated clinics. Because and I say this with sort of all due deference and respect, I think that if you can make it happen in the county-operated clinics, you can make it happen almost anywhere, right? So the lessons that we're going to learn, I think, are going to be valuable, and we're excited to disseminate them. Yep. I go so fast, and I'm sorry. This is the contact information for our study coordinator.
And it's in your the email that I sent with the links to be able to look at all of these slides are available.
I'm going to yield the podium. Please.
Do you need to get hooked up, or?
No. I just didn't bring my printed out thing, so I'm going to use this. I'd like to call up Melissa Goldman. We need to pause and have a pause for the sponsor, who is providing all of your lovely CEUs for today. So we got to give them a time to do what they need to do. Thank you, Melissa.
Good morning, everybody. My name's Melissa, and when you signed in this morning, either if you signed in for CE credit or if you signed in just regularly signing in, you should have received a yellow evaluation. If you didn't get a yellow evaluation, please see me. This is our post-event form and should be completed at the end of today's session, and it should take no more than 15 minutes to complete. The evaluation is mandated by the Government Performance Reporting Act and is also referred to as a GPRA. Your feedback will help us provide better, more effective, and relevant training and technical assistance opportunities to behavioral health, primary care, and recovery support practitioners across HHS Region 9. Not all questions on the post-event evaluation will conform to the structure of today's event. These forms are regulated by SAMHSA, so we are unable to modify them in any way. Please try to provide the best answers possible and turn in your gift or evaluation at the end of the event. To protect your anonymity, there's a unique alphanumeric identifier code located at the top of the first page and at the bottom of the second page of the survey form. Please ensure that these codes match one another. We ask for the first letter of your mother's first name, the first letter of your mother's maiden name, the first number of your Social Security number, and the last number of your Social Security number. This unique identifier will be used to help link your responses to the post-event evaluation form and any other voluntary information you decide to provide. So, bottom line for the yellow form is that everybody needs one, and then at the end of the day, when you're done with the event, please give it back. And there's also a section on there if you'd like to be included in like a post-event evaluation. You could be entered to win a gift card. So that's the spiel that I have.
Thank you.
Thank you, Melissa. We're really grateful for ISAP providing those units, especially for your counselors, because it seems to be difficult for the counselors to be able to get those units. So we're happy that they were able to provide those for us. And it does not look like. Oh, here we go. Okay. It's not showing the. The video, yeah, it's not showing in there.
It's right here.
Yeah. Don't start it yet. Good morning. Thank you again for coming. I just want to show you a short video about the work that I've been doing as community engagement specialist. I know a lot of you from the alcohol and drug or substance use disorders field. I'm co-founder of Shields for Families. I know you from the mental health world. I know you from the child welfare world. I know you from being around LA for 40 years or so. But this is just some of the work that I'm doing. Thanks.
Yes, sir.
Mm-hmm.
Hi, I'm Norma Antonia, and this is my story regarding community engagement. More recently, I've been thinking about medical care in South Los Angeles from a historical perspective. I grew up in Los Angeles in a poor neighborhood. From childhood to early adulthood, I received some basic primary care at a local doctor's office. However, when we didn't have insurance and cash was low, it was off to the old county hospital where a basic visit could take an entire day. I remember traveling a long distance to see a doctor, especially for specialty care. We would take 3 buses to get to the hospital and the clinic until a county facility was built in a more immediate community when I was 22 years old. I remember smaller local hospitals where my siblings were born and some county clinics, but they didn't provide the care we needed. Only recently did it dawn on me that many Black doctors lacked the admitting privileges in major hospitals. Consequently, after providing prenatal care and other care in their offices, they sent their patients to hospitals where they were allowed to practice. I have been interested in the body and numbers for as long as I can remember and preferred math and life sciences in school. I loved physical education and running street races with the neighborhood kids. I decided that I wanted to teach math and physical education when I grew up. Consequently, I began Cal State University of Los Angeles with a physical education major and a math minor. As time went on, I realized that it wasn't just the body I was interested in, it was overall health. Not much had changed since I was a little girl. I wanted to help make a change to ensure poor people could be well. In my sophomore year, I became involved with neighborhood social services and helped to start and direct a free clinic in South Los Angeles. My interest grew to include a more holistic approach to health care, and I returned to graduate school to study more about health and mental health. During my career, I helped to establish and serve in leadership for 2 other community medical and behavioral health clinics in Los Angeles and Berkeley, California. 8 years ago, I became involved with Charles Drew University and the University of California at Los Angeles Medical School's research endeavors around community engagement. I was invited to work with the schools and their students to help them develop best practices to engage with their patients in the community. I work with basic science researchers who are hard at work looking for causes, developing treatments, and hopefully finding cures for many illnesses and diseases that plague our poor and under-resourced communities, like those in South Los Angeles. Here, research is being conducted with and not on communities. As an individual with a diverse background, I participated as a full partner of non-traditional research teams in what is called community-engaged research. I serve as a community representative on advisory boards that oversee the overall project. I have conducted interviews, facilitated focus groups, and participated in planning events to disseminate research results back to the community. Unfortunately, things still haven't changed much since I was a child regarding poor health outcomes in my community. Poor people still have the highest rates of disease, disability, and preventable death. For instance, the decrease in smoking cessation rates across the nation still are not translated to lower rates of tobacco use in African American communities. My work over the last 8 years has culminated in my latest project, where I will be working with the research team to implement smoking cessation services in Los Angeles County mental health and health services clinics. I no longer consider research as something mysterious, but as something that warrants my attention and involvement. I work now to help with educational and health systems change to reverse these trends to ensure a longer and better quality of life for those in my community. Health science research studies are important because they help us to better understand illness and disease and what prevention, interventions, and treatments might work best for various populations. Most community-engaged research is paid for with your tax dollars. So why not join me? Learn more. Get involved.
Thank you. And I just have to help set the stage here. You can see that I'm one of the potential statistics in this community. This is where I'm from, and these are the folks that we work with every day. I just like to help set the stage for us to be thinking about all the information to be presented today. And we're going to be talking really fast because we've got a lot of information we want to share with you, but you will have the PowerPoints and the presentations will be available for viewing online afterwards as well. Like I said, I like to set the stage and how it might relate to the patients and clients that you serve and what you will do with the information when you leave. You can go ahead and set up the next one. I've spent most of my life and career building and helping to run nonprofit organizations in South Los Angeles and similar communities. By similar, I mean communities where health disparities abound. As you are all probably aware, smoking has been shown to have a direct causal or significantly exacerbating relationship to conditions such as cardiovascular disease, chronic obstructive pulmonary disease, asthma, emphysema. Moreover, research shows that smoking can be detrimental to all systems of the body. As a community engagement advisor, one of my roles in this project is to help ensure that we keep the real goal of our work at the forefront. We do the work we do to help save lives and to help our patients have a better quality of life. Some days I feel like a casualty of trauma and disparities. What I mean by this, my mother and paternal grandmother, my maternal and paternal grandmothers died from strokes. One also had diabetes. My mom was killed in an accident while working for LA County. An elevator crushed her. My brother was murdered about 6 months after my mom passed away. Another brother, a smoker, died from colon cancer after botched surgery while incarcerated. One more brother had a series of strokes, and we suspect it was a stroke that caused him to crash his car on the freeway one day and die from internal injuries. I'm just getting started. My sister died at the age of 50 about 2 years ago. She had Parkinson's disease, diabetes, high blood pressure, and asthma. Did I say she smoked? Her husband passed away last month from cancer. He smoked. And I haven't even touched on the mental health and HIV cases in the family and dear friends, most of whom also smoke. I'll end this list with my dad and dear friend, lest we need Dr. Hurley to prescribe us some Zoloft. Prozac or something like that. My dad, who was always my biggest cheerleader and hero, died from lung cancer 10 years ago. In 6 months, I watched him go from a robust 185-pound, fun-loving grandpa to 95 pounds in 2 weeks to stand on his own. He covered the mirror in his room because he couldn't stand to see his reflection. To emphasize the addictive quality of nicotine, he had 3 heart attacks before he quit smoking. But by then, unbeknownst to any of us, the lung damage had already occurred. Also, one of my dearest friends in 7th grade is waging a battle with lung cancer. Both of them smoked and had the hardest time quitting. So you see, my work with this Smoking Cessation Project as a community engagement specialist is personal. I realize I am but a step away from being one of the statistics we'll hear about today. I want to help see that others don't have to watch family and friends suffer and die from smoking-related illnesses as I've done. The best plan is to prevent ever starting to smoke. The second best plan is to intervene as soon as possible. I believe that integrating smoking cessation services into mental health and medical health clinics is moving Los Angeles County in the right direction. I'm proud to be a part of the team and look forward to better outcomes for patients struggling to rid themselves of this nasty habit. I figure that I must be still standing and have great health at nearly 70 years old for one reason, and so I continue to do the work I do.
Great job, Norma. Very touching. Give Norma another hand. So, instructions for the speakers: please adhere to your time limits. We'll give you 1 and 5 minute warnings. The 2 young people in the front here will be definitely, you'll see them. Speak into the microphone. Allow time for questions and repeat the question. The audience, please return to your seats promptly after breaks. Keep your cell phones off. Keep your questions short. And to direct them as questions. Especially want to thank the California Tobacco-Related Disease Research Program, TRDRP, for grant number 828CP0040. Friends Research Institute, Frank Vacci is the president, and Jennifer Reyes is their administrator. She's fantastic. And Department of Public Health Tobacco Control and Prevention Program. I'm Theodore Friedman. There's my email up there, and we have Dr. Hurley's email over there. We are running this program and happy to answer questions either now or later. Be in touch with you. We'll invite you back next year for our 2nd annual event. Any questions about the introduction? Laura, do you want to come up?